welcome everybody to our April Unite. We are really excited to welcome also Dr. Roth, who Matt will introduce momentarily. But before we do that, just some updates. We do obviously want to thank our industry partners as usual because they make this program possible. There's quite a lot of work that goes on behind the scenes, believe it or not. So we're grateful for ongoing funding. I'm going to leave the intro to Matt in just a moment, but we are really privileged and delighted to have Dr. Roth with us. She shares her expertise in the sleep space. Do follow us on social media and keep up to date with the Living With. I actually had a really wonderful conversation with Dr. Shelby Harris last week. So that video series, that interview on actually cognitive behavioral therapy and related issues will be released, I think, next week. So do follow us on social media and YouTube. And of course, all of these programs you can find on our website. If TikTok is your thing, then you'll be delighted to know that we have a TikTok channel. We work with a wonderful person called Elizabeth Wyndham, who runs our social media as well as our videos and all sorts of other things also behind the scenes. And TikTok is very current. We also work with other advocates in the space. So you'll see some familiar faces if you hop over to TikTok. Okay, the big news actually is to please join us in May in person or virtually, but we would really love to see you in Houston for our annual Beyond Sleepy conference. It starts on May 31st and goes through June 2nd, and it's a particularly special conference for us this year because we'll be celebrating the first Idiopathic Hypersomnia Awareness Day. That's going to be on the front end of the Idiopathic Hypersomnia Awareness Week with our collaborators and advocacy partners in Australia. We're also going to be celebrating 10-year anniversary of the Hypersomnia Foundation and recognizing champions that have been with the foundation right from the gate. But of course, we've got wonderful speakers. And again, on social media, we're profiling them at the moment. You'll recognize some of the experts and researchers that will be speaking, such as Dr. Trotti, Emmanuel Mignot, Yves de Villiers, and so many more. But also, we do have a young person's track that's also first time we're doing that. And also lots of patient speakers as advocates as well, as we begin to recognize and push forward with advocates and patients being the experts that we already know you all are. So please do join us for Houston. Registration is up on our website. It's also showcased in our newsletter. So registration's open. Please check it out and join us. It's going to be great. There's also some social events, lots of opportunities to connect. I've already said this, but if you don't know where our website is, it's right there. It's actually been revised and relaunched, our website. So hopefully you're going to find it more easy to navigate on your cell phones or on your laptops. And I think that's all from me. Thank you. All right, Matt, over to you.
Okay. All right. Thank you, guys. This is going to be the most riveting part of the entire night. It's me reading off the disclaimer statement. So please bear with me as we get through this part and we can get into the meat of the presentation. So our Unite virtual forum is an educational and supportive in nature and will offer self-care strategies to help you in your daily life. However, the group will not engage in rendering any psychological or healthcare advice for any particular individual or situation and will not provide medical, mental health, or any other type of health-related service. No diagnosis, treatment recommendations, medication advice, or any other type of medical or mental health recommendations will be offered. Our support group is not a substitute for or alternative to treatment by a licensed medical professional. Always seek the advice of your own physician or other qualified healthcare provider with any questions you may have regarding your medical condition. The Hypersomnia Foundation does not recommend or endorse any specific tests, physicians, lawyers, legal advisors, products, medications, procedures, opinions, or any other information that may be referenced on its website or during any online support groups. So with that, I am proud to introduce Dr. Alicia Roth. She is a Ph.D. DBSM, which is a diplomat of behavioral sleep medicine, is a clinical health psychologist and staff at Cleveland Clinic Sleep Disorders Center. She's also board certified in behavioral sleep medicine. She completed her doctoral training at the University of Florida, internship at Baltimore VA, and behavioral sleep medicine fellowship at the Cleveland Clinic. Her clinical work focuses on treating a range of sleep disorders, including hypersomnia, circadian rhythm disorders, central disorders of hypersomnia, and nightmares, as well as CPAP desensitization. She has published numerous research articles on the intersection of sleep and chronic health conditions, ergo fibromyalgia, heart disease, and persons with Alzheimer's and their caregivers. Dr. Roth's current research focuses on the implementation of population health initiatives for insomnia treatment, as well as developing treatments for central disorders of hypersomnia. In 2022, she was awarded with the Society of Behavioral Sleep Medicine's Early Career Behavioral Sleep Medicine Advocacy Award. So with that, I also just wanted to add that Dr. Roth has been a big influence in my journey in advocacy as well. I've had the honor of knowing her, as Twitter friends, but also have ventured into some professional collaboration here recently. I think the world of her expertise, and it truly is an honor to have you here to have us to enlighten us this evening about that intersection of mental health and central disorders of hypersomnolence. So I turn it over to you and look forward to learning tonight. And for those of you in the audience, please keep your mics on mute. And if you have a question during the Q&A, please put that in the chat or raise your hand and we can cycle through and get to you in a reasonable fashion. So Dr. Roth, your show.
Thanks so much, Matt. That was like a really sweet introduction. And I appreciate everything you said. Welcome everyone. I'm going to share some slides because what would a doctor be without their slides? Can someone give me a thumbs up just to say they can see them? Great. So again, my name is Alicia. I am one of the clinical health psychologists here at our Cleveland Clinic Sleep Disorder Center. And I wanted to talk today about some the research that has been done in this field about the intersection between mental health and central disorders of hypersomnolence. Now, I usually give a presentation like this to providers who have no idea what central disorders of hypersomnolence are. And they know narcolepsy from a very stereotypical movie perspective. So when I am describing to people who don't understand what this is, usually other providers, not like lay people, but other providers, I'm trying to put it on a level of a chronic illness. In fact, I'll say, just imagine that you have a chronic, incurable neurological disorder. And I kind of get them to sit with the ideas of what those symptoms look like. It's not the Hollywood version. Narcolepsy is not that. And I don't need to convince anyone here that narcolepsy or IH or any other type of hypersomnia is like that. So we know all the symptoms, and y'all are probably much better experts than I am in this because you experience this every day. But once I impart the constellation of sleep symptoms to other providers, a lot of other providers don't know that poor nighttime sleep is an issue. They don't know about sleep paralysis. They don't know about hallucinations. They don't know about cataplexy. Once they hear this constellation of symptoms, they're usually like, wow, how can anyone function with that? And that's precisely the point. And I think for anyone who has a hypersomnia disorder, or for someone who works closely with people with hypersomnia disorders, I think it's sort of like a common sense. It's like a given that your life, your functioning, and your mental health are impacted in a negative way. But it is really important that from a science perspective, we have identified and categorized these kind of common sense ideas that we have as providers and as patients. So I wanted to go over tonight what we know in the field, in the literature, and in the systematic reviews of what we know about mental health and disorders of hypersomnia. So a lot of these things are going to sound like, yes, we know that, but I think it's important that you know that it is well researched and well documented. So there's research showing that from a functioning standpoint, people who have disorders of hypersomnia, the experience just getting to a diagnosis is incredibly difficult, and that is well documented, that people have decades of their life that they go misdiagnosed. They go misdiagnosed with mental health conditions or other sleep disorders. That is very well documented. The comorbid or co-occurring psychiatric illnesses are well documented. I'm going to show you a study that shows that the stigma surrounding hypersomnia is quite severe, and is quite severe in young adults. Negative self-esteem, difficulty with relationships and functioning in all different types of relationships, romantic relationships, friendships, family relationships, parent-child relationships. And then occupational problems in school or work. So all of these things have been really well studied and documented. One study here that came out in 2016, and I put the title of this, I never put the title of a study when I'm citing it, but I thought that this title just like, bang, it really just stood out to me. The humanistic and economic burden of narcolepsy. And in this study, it was a survey of about 175,000 American adults from 2011 to 2013. And it 2-to-1 propensity matched people without narcolepsy and people with narcolepsy. So 2 times people without narcolepsy to the 1 time of people with narcolepsy. So we have about 874 controls, 437 people with narcolepsy. And they compared and contrast the diagnoses, the mental health diagnoses that these patients had. And this is what really stands out. So amongst controls, 25.9% had clinical depression. And amongst people with narcolepsy, it was 48.3%. And that was a significant difference. Bipolar disorder, which is very severe and very impairing in and of itself, the controls people without narcolepsy 4.6%, which is about what it is in the regular population of people. But amongst people with narcolepsy, it was 14.2%. And the propensity of having any anxiety disorder, which there are a list of anxiety disorders here, generalized anxiety, PTSD, social anxiety, etc. But having any type of anxiety disorder was more than double. For controls, it was 22.2%. For people with narcolepsy in this study, it was 51%. And this study only included people with narcolepsy. It did not include people with IH, which you are going to see there's a trend there that people with IH are sometimes left behind in these studies. This more recent article from 2020 was a review that showed all of these things all of these diagnoses are being seen in people with central disorders of hypersomnia. Cognitive impairment, depression, schizophrenia-like symptoms, which that is very severe, that is very functionally impairing on its own. Anxiety, ADHD-like symptoms, eating disorders, and what we call REM sleep behavior disorder, which is a disorder where you act out your dreams during REM sleep. And so the research in this area is pretty clear and pretty, I would say, not shocking, but because I know this population, but to anyone who doesn't know this population, pretty shocking. It's probably more psychiatric comorbidities than other chronic health problems. So this is a great study that came about 10 years ago looking at young adults. So it, again, narcolepsy versus no narcolepsy, no IH here. And it was the young adults with narcolepsy, their average age was 27 years. The controls without narcolepsy, they were 25 years. This sample is mostly female and mostly white. But nevertheless, they were looking at stigma amongst these young adults with narcolepsy. And they found significant differences between narcolepsy, persons with narcolepsy and persons without narcolepsy in terms of social rejection, financial insecurity, internalized shame, and social isolation. Now, those are very general. Those are very kind of broad things. It wasn't specifically asking, do you feel social rejection because of your narcolepsy? So certainly, young adults can feel all of these perceived stigmas, and it's not zero in the control group, but within the narcolepsy group, it was much, much, much higher than in the control groups. And even without getting like a formal diagnosis of a mental health condition, going to a doctor or a psychologist or a psychiatrist and being told you have depression, you have anxiety, you have PTSD. People with disorders of hypersomnia just report more symptoms that are related to mental health. So this was a study that did include both narcolepsy, people with narcolepsy and IH, and showed that there was a really high percentage of all of these kind of vague anxiety, depression symptoms like sad mood. Sad mood was 80.6% of the people in this study. That was 299 to 300 over 300 patients. Lost interest, irritability, social isolation, concentration, guilt or worthlessness, anxiety, or just generalized worry. These are really, really high numbers. I was really inspired by the series of studies that came out of Northwestern University a couple of years ago that started started the ball rolling on really developing a scientifically proven treatment to help people with hypersomnia disorders from a psychosocial, from a mental health perspective. And one of the things that this group did was they started with focus groups to ask about what is going on in your life that is being affected by your diagnosis of narcolepsy or IH or some sort of hypersomnia. So I'm sure that many here have heard these things before. So negative perceptions, people say, I don't think you have narcolepsy. I think you're just tired, or I don't see you look fine. You don't look like you have an illness. Self-esteem and self-efficacy. These are direct quotes from the paper. I feel like I've gone in my head from someone who's capable to someone who's not capable. Their social life, I can't keep in touch. I can't follow through. I can't meet up with them. I can't be invested. Occupational functioning. This one really stood out to me. The need to sleep is so strong that you think, well, I'd rather lose my job and be homeless if I have to, because I have to sleep. That's a really powerful statement. Family planning and relationships. So I'm scared to pursue intimate personal relationships because of my cataplexy. And physical symptoms. It's almost like we're addicted to sleep. That also stood out to me too, is you're trying to rid yourself of that craving for sleep and it never quite goes away. So this was a wonderful study and a series of studies that looked at what is functioning like, what is real life like for people who have these conditions. But here's where the problem is. The field has done an incredible job, and there's much, much more out there than I just kind of gave you the overview of the science and what we know. There's lots out there where we have identified, cataloged, and sought to understand the experience of people with hypersomnia conditions. But when you go to what are the clinical guidelines? What are we doing as a field in sleep medicine and in sleep psychology to help this population? The clinical guidelines are hardly existent. So what I mean by clinical guidelines is the American Academy of Sleep Medicine, which is the biggest group in sleep medicine in the United States, probably in the world. It's a multidisciplinary society. Probably hundreds of thousands of members. It's physicians, neurologists, pulmonologists, sleep center technicians. I'm sure many of you have met sleep center technicians, nurse practitioners, psychologists. It's a big group with lots of different types of providers. And they issue guidelines for how do you assess for these problems and how do you treat these problems. And this is a really big deal when the American Academy of Sleep Medicine puts out these papers, because it means that we now have scientific evidence to use these treatments, but it's also important for insurance. So when we get a call from an insurance company saying, we're not going to pay for this, we're able to go back to these clinical guidelines and say, this is published scientific guidelines by the biggest society in sleep medicine. And that goes a long way in getting insurance approval for things like, not just for, psychological treatments, but for things like your sleep studies, MSLTs, maintenance of wakefulness testing, any sort of the testing that you've done for hypersomnia conditions. The reason you're able to do that and have insurance cover it or not cover it is because of these clinical guidelines. There are no clinical guidelines on how to help people with narcolepsy, IH, other hypersomnias, with their psychosocial mental health functioning, or any guidelines for behavioral interventions. So interventions that aren't pharmacological, aren't medication based. In the 2007 guideline, the only behavioral recommendation is scheduled naps can be beneficial to combat sleepiness, but seldom suffice as primary therapy. We all know that scheduled naps is not primary therapy. And when it says guideline, it means it has okay evidence. It's not the strongest, best treatment for narcolepsy, but it's okay. Basically, from a scientific standpoint. The updated 2021 guide didn't change in terms of what is out there from a mental health or behavioral health perspective for people with hypersomnia. So there's the gap, right? We know this is going on. There's a big literature on what happens to people with hypersomnia disorders, what happens to their lives, but there has been nothing that has reached the level of clinical guideline. There's certainly a lot of resources to help. I like to say that the hypersomnia patient population, y'all are so well informed and organized, and the fact that this Hypersomnia Foundation exists is proof of that. You're a very involved and active and proactive patient group, and that's wonderful. And so you've created things, I think people with hypersomnia or who have loved ones with hypersomnia have created their own networks and resources, but the science is lagging. And when it comes to behavioral interventions, the group at Northwestern sort of asked people, like, what are you doing? What are you doing that's not medication based or pharmacological based? And if you look at the table on the top left, it's sort of a list of things that people with narcolepsy and IH do to try to help themselves. So the most common one was daytime naps. So 85.9% tried to use daytime naps. Scheduled nocturnal sleep, caffeine, exercise, diet, temperature manipulation, chewing gum, nicotine, mindfulness, yoga. Very few said they don't try any non-medication strategies, only 3%. And then they compared that to, well, how helpful are these strategies? How helpful or effective are they in managing some of your symptoms? And on a scale of 0 to 10, so 0 being not effective at all, 10 being the most effective thing were daytime naps. And it was only a 4.3. So the most used and most effective thing, that behavioral recommendation that we have, are daytime naps. And it's only a 4 out of 10. Right? So clearly the behavioral recommendations that are given to people with hypersomnia disorders, they're not helping manage symptoms, and they're certainly not helping manage all of those things that we just talked about in terms of mental health and the impact on functioning. So like I said, the group from Northwestern did a series of studies to create what they call cognitive behavioral therapy for hypersomnia. I'll call it CBT-H for short. And they describe this as an adjuvant treatment for central disorders of hypersomnia. So an adjuvant treatment means it's not the primary treatment. It's not the treatment that's going to cure it. We're gonna completely eliminate it, but it's going to be helpful. And this treatment was specifically aimed at improving psychosocial functioning in people with hypersomnia disorders, and it included all types of hypersomnia disorders, not just narcolepsy. So I think that was a really great move to include IH into the fold of the scientific literature. So they started out by doing a survey. You saw some of those surveys that I just showed. What behavioral strategies are you using? What interest would you have in an intervention like this? They ran some focus groups to further elicit, and then they did a feasibility study to see, like, how will people like this? How will they respond to it? How will their symptoms or hypersomnia symptoms improve? How will the mental health and functioning improve? Cognitive behavioral therapy in general, we can apply the concepts of cognitive behavioral therapy to really any type of mental health or a mental health disorder or illness. The idea behind cognitive behavioral therapy is that there are behaviors that we do that become part of the problem. And then there are cognitions. Cognitions meaning thoughts, emotions, beliefs, attitudes, appraisals, what goes on in our head that contribute to the problem. And everything kind of becomes reciprocal. So for example, in depression, people who are depressed, because they're depressed, they maybe aren't active socially. And they don't do much socially, but not doing much socially might make their depression worse. And so things become reciprocal. And that's what we're doing in CBT, is trying to understand what are the cognitive and behavioral things that are making this problem worse and becoming reciprocal. So that's the basis, that's the foundation of CBT for hypersomnia. But in general, this is what the Northwestern study put together based on their focus groups and surveys. So 1 week was education about hypersomnia. And then self-identity and self-image, structured daytime activities, structured nighttime activities, coping skills and emotion regulation, talking about social support, medical, legal, and occupational issues was 1 week. And then there were other topics that you could take or leave based on the patient. And they did this with patients who both had narcolepsy and IH, and I think other types of hypersomnias. They did it in both groups, and they did it one-on-one with patients. And so they really did a variable approach to see. And this was before the pandemic. So they also did in-person versus virtual. It's hard to remember what it was like to see each other in person all the time. I think one of the silver linings of the pandemic is that we can do things virtually now, but that was something that they experimented with as well. And they did find that this was an acceptable treatment. So the participants involved liked the treatment. They gave feedback on what they liked, what they didn't like. It was very different for each individual. And I'm going to talk to you about how I found it's different for each individual as well. So I ran two groups of this treatment at the Cleveland Clinic. It's a new treatment. Wanted to see how it would work, kind of see how patients would like it. So we did 6 weekly sessions. It was in a group and it was over Zoom. So it was very easy for everyone to be involved. It just happened to be that in both of my groups, I had a really good mix of types of hypersomnia. So type 1, type 2, IH. And so people were having a lot of different symptoms and experiences. Gender was pretty stratified or pretty diverse, and age was pretty diverse too. But the takeaways that I got from doing this, the CBT for hypersomnia, that patients did want help with certain symptoms. They wanted help with sleep inertia, which is very, very challenging to both have and to treat. They did want tips on daytime productivity if they had to work. But the last 4 things are what people really wanted to talk about. That weren't always on my agenda, but I was like, all right, we're going to take this in whatever direction that the participants want. They wanted to talk a lot about disability and accommodations, which I totally understood, but had very little knowledge of. So I have tried to learn more about the disability and accommodations process. Mostly people wanted to talk about loss and grief. The loss of careers, the loss of relationships, the loss of their health. There's a lot of anger. There was a lot of talking about how do I manage relationships with other people, new relationships, old relationships, spousal relationships, child-parent relationships. My patients didn't want tips and tricks for how to be more awake during the day. They wanted to talk about the devastation that this had caused in their life. And even if I had one patient say, even if tomorrow, with the flip of a switch, my narcolepsy went away, I was completely cured and I was fine, it wouldn't erase what's already happened, because it's been decades of my life that have been changed or devastated by this problem. And so that really got me thinking, what are we missing here? You know, we're missing, there's kind of a disconnect between where the research is going on mental health and hypersomnia, and what patients are asking for, what they're kind of craving for in a treatment. So we have opportunities for innovation, and that's very exciting for me as a psychologist and as a researcher. But the opportunities here for us on the science side is to focus on the experience of people living with these conditions and focus on living the best life possible. This is not a condition that's going away. It's not going to be completely cured. We know that. It can be very well managed, but not aimed at problem solving, not aimed at making people the most alert. Because when you go into for your follow-ups, for your medication renewals, the doctors ask a lot about, like, what's your alertness? Do an Epworth sleepiness scale. How well are you able to maintain wakefulness at work? That doesn't really get to like the heart and the core of what people with hypersomnia are really experiencing. And so my plan and idea is to take an approach, a different approach to helping people with hypersomnia, that is based in acceptance and commitment therapy. So I want to talk about what acceptance and commitment therapy is. We call it ACT for short. And this is effective across a range of chronic health conditions. ACT has been very well studied in things like chronic pain. And so I rotated in clinics, chronic pain clinics, and I found that I have a lot of ACT for pain books. If I read an ACT for pain book and I just find and replace pain with narcolepsy or IH, it makes sense, right? This treatment makes sense for what I'm hearing from patients, but also what I'm seeing in the larger science community. So what ACT does is, the idea behind ACT is that pain is inevitable, suffering is optional. And it's not about managing symptoms. It's not directly about managing wakefulness or managing sleepiness. It's about how do I live my best life parallel with narcolepsy? How do I live my best life parallel with IH? And there are kind of 6 concepts within, we call it the ACT hexaflex. The 2 main concepts being acceptance, being open to whatever comes, and self as context, which is awareness of your thoughts, your moods, and your actions. And what I focus on with patients in ACT is to understand, what are your values? What is important to you in life? Is it being awake and alert? Or is really the value behind that, I want to be awake and alert so I can attend my kids' soccer games? Do I want to be awake and alert because it means I can have a fulfilling career, the fulfilling career that I've always wanted? Those are values. And trying to explore what's important to people in life and helping people move towards that, and helping them do that aligned with and parallel to their experience with narcolepsy or IH. So what's next? Like I said, we have lots of science to show us what people with hypersomnia are going through. And I think we're done with the awareness. Well, I won't say done with the awareness. The awareness never ends. But we need to move into action in the scientific and treatment community. We as scientists and providers need to move into the action phase of helping this population. And so like Matt was saying, I am trying to get funding to start a series of projects to explore this idea of acceptance and commitment therapy. So I want to first start with focus groups, understanding what my patient population is going through, if this would even be acceptable or interesting to them to do. I don't want to just throw a treatment at people that they're not even interested in doing. And then develop this treatment, and then do a short feasibility study to see how this works out for patients with hypersomnia. So everyone send good thoughts and good vibes to the grant funding gods, so I can start this work. But thanks to all of you for being here, and your advocacy and your interest. Like I said, I I love my patients with hypersomnia because they are the most informed, they are the most active, they are the most proactive group of patients that I have. And it's really lovely to work with this group. And I want to put my, my credentials and my ability to do the science to work so that we can improve life for everyone. So with that, we'll go to questions, I guess.
I'm so glad that you're here sharing this, because I think it's such a much needed topic. Shelley's over there nodding her head, and we talk a lot about ways to help people improve their mental health. We in groups, and we always recommend that someone go see a behavioral sleep specialist. It's hard to find one who's who's qualified for hypersomnias, but you certainly are. But oftentimes we have to suggest what to discuss with their mental health practitioner, and this is something that I've started to kind of sprinkle in and be like, hey, this is an option. But it also coincides with intuitively what I tried to do for years, which is, how do I live my best life with this condition? And to have a system that breaks it down, I think, is such an important step. I don't want to talk this entire time, so if we have some good questions, I know that we had a lot of well wishes and whatnot in the chat, but is there anybody who has any questions specifically for Dr. Roth related to mental health? So Shelley just wants to say, is there anything we can do to help moving this forward? It sounds amazing. We would love to see it rolled out, and start with that one.
Yeah, I think the fact that this organization exists helps. The Hypersomnia Foundation does provide grant funding. Other hypersomnia-based peer support and peer-led organizations provide grant funding. Most of grant funding is still from the government, and so that is always very difficult to obtain. And then a lot of grant funding comes from the companies who make the medications, the pharmaceutical companies. But I think the existence of these groups, especially the Hypersomnia Foundation, and being active and supporting and fundraising is the best thing you can do, because I think people in my profession are quite surprised there's not like an insomnia group. There's not a there's not any kind of peer-led expert group like this. So that's the best way that you can support this research, is to continue to support groups like this.
Yeah. Thank you.
Yeah.
There's a question here too. I'm going to get back to a specific question about that someone's asking, but
Okay.
And I'm going to drop a link in the chat to help you answer this question. But where do you search for behavioral sleep specialists?
This is really tough because, as Matt alluded to, there are very few of us. In psychology today, I think a lot of therapists will list like sleep as a specialty, but they don't really have any specialized training in sleep. I will drop a link.
I think I have it pulled up for you.
Behavioral sleep. Yeah, there you go. So the Society of Behavioral Sleep Medicine is a group of behavioral sleep medicine providers, and we're kind of a specialized, mostly psychologist group. You can search there by state as far as the members involved. There's a lot of members who, as far as psychologists go, we cannot cross state lines to provide treatment. So even though it's virtual, I have to only see patients who are in Ohio, unfortunately. But now there is a certain license that allows people to cross state lines to do telehealth. So a lot of SBSM members have that. Behavioral sleep specialists typically don't take Medicare or Medicaid. That is true if they're working in private practice. If they're working at a large academic medical center or hospital like I do take Medicare or Medicaid, because I just work in a big institution that can do it. But when you get down to like private practice providers, they usually don't take it.
Yeah. I know that SciPact is a piece of that puzzle, and certain providers in certain states and can see folks across state lines. And I'm going to put a list of those cooperating states in this list here, so people have an idea. But I guess one question that to follow up on that, because I've heard of some people reaching out and having trouble finding someone who, again, amongst that list of SBSM providers, I usually recommend that they ask, do you currently see patients with hypersomnia as a screening question too?
Yeah, that's a really good point, because a lot of people say they are behavioral sleep medicine trained, but really their training is only in insomnia, and they don't have experience with hypersomnia or any of the other more severe sleep disorders like nightmare disorder or things like that. So another way to search for board certified in BSM, which means they know everything, they know the whole gamut, is to look up the diplomates in behavioral sleep medicine. There's a list of them by state. Matt, do you have that, or is that something I can
I'll
look
pull
up?
it up right now. I'll
Okay.
pull it right now so you can, yeah.
And so people with the credential is called a DBSM. They are board certified, and that means that they don't just know insomnia, they know hypersomnia as well. Allison's question, if they're board certified, aren't they typically just in a hospital versus private? No, there is a good mix. People who have DBSMs are both private and in big hospital settings as well. There was another question. Oh, okay. I'll answer the question from Cheryl while Matt looks that up.
Thank you.
So Cheryl said, given that I started CBTH with my therapist about 4 to 5 months ago and then get stuck on the Pomodoro technique. Okay. My schedule is different every day due to my medical and work schedule. He wouldn't go past session 3. How would I recommend he go past that? If Cheryl is here, you can unmute yourself.
Yeah,
but
I'm here.
Oh, hi, Cheryl. So, yeah, is the person you're seeing a behavioral sleep medicine specialist?
No, so I got was it Dr. Ong? Is that who did the CBTH? So I had seen him speak, and he said if we had a therapist, he would provide the program. So my mental health therapist requested it, got the program, and he was very willing to work with me. We used to have a behavioral sleep therapist here in Massachusetts, and he retired like, I don't know, like 10 years ago, and left all of his patients high and dry. And so we don't have anybody. And my sleep neurologist is in Boston, and even there, I wasn't able to get anyone. So all I could do is work with a regular therapist. But what he was trying to do was, as you're supposed to break things down into little pieces. And he literally says, well, break things down into like 15-minute to 30-minute periods. And I'm like, no, you can't do that. He says, well, what do you do as soon as you wake up? And then right after you wake up, you go to the bathroom, and then you brush your teeth, and then you take your medicine. I'm like, fine. Well, I do that for the first 15 minutes, but then after that, every single day is different. I may have doctor's appointments, or I may have to run out and see a customer, or I'm sleeping late, or my PCA is with me, and when she's with me, now I have to do this. I said, I can't break up every single day into something. And then as far as the naps go, my sleep neurologist told me she doesn't want me taking naps. So I can't even break up my day into having sections and having naps in between. And I'm like, can't we just jump to the next one? And he's like, well, I'm supposed to do this. And it sounds like from what you just said, you're almost stopping that section. Like what you're hearing from people is that's an area that people don't even want help with.
I think the issue that you're describing really illustrates what I've been seeing with patients is it's when you really focus on like these behavioral strategies to increase alertness, increase productivity, it's going to be so different for everyone. And so as a provider, you really need to understand these conditions to know how to make it work for people, because there's not just one kind of square way to make it work. But I think what you're experiencing is like, it's not, you're focusing so much on this like hack, so to speak, of like how to be more productive during the day. And the Pomodoro technique works really well for a lot of people. Don't get me wrong. I think it's a great technique. But it's, like you said, it's not what I'm looking for. It doesn't fit me. And it's showing this disconnect between, I think, what a lot of providers offer or know how to do. They just throw it at you because they're like, this is what I know. I know so little. So this is what I know. I'm just going to throw this at you. And if you can't do it, I have nothing else. And that's where the disconnect is. It's not it's not something that people are saying that they want. They don't want these productivity hacks. They want to be more productive, but this is not the way to do it.
So I should safely just say to him, look, you keep coming back to me and saying, are you ready to do this? Are you ready to do this? And I keep saying no. And he's like, all right, then let's just do talk therapy today. So I should say to him, let's just skip that one, go to the next one and see what we can do to try to finish the program. And I did some little snapshots from, your screen and all, and took some notes, and I see him on Thursday. So I'll have a little discussion with, I would think after all these months, I would like to be able to finish the program and maybe get something out of it, because all it was been doing was stressing me out. And where you're supposed to pick which things, are sucking your energy out and which ones are giving you. Every time I was sitting down with him, it was just sucking my energy out. And that's the opposite of what I want to be doing. So thank you. Thank you for mentioning it. And I think
and I always tell people, when you're working with a therapist, if you're unhappy with what you're doing in therapy, you have to speak up and say, I don't like what we're doing, because it doesn't mean that you're wrong. The therapist is wrong. It might just mean that you're not on the same page about what your needs are. This is what I need to work on, and I don't feel we're working towards this. And I say this to people who do all types of psychotherapy, but this is not easy, but being assertive with your therapist to say, this is what I need and this is what I don't need.
I think that's a great point too. And this is a relationship that you guys are having together. You're working on a problem collaboratively. This is not a one-way street, so to speak. I see Shelly has her hand up, so I wanted to let her have a chance to offer some perspective or question.
Yeah, thanks. I just had a quick question because I'm not familiar with this. I Googled it because I was like, what is this? This seems interesting. And looking at it, it seems like it's the type of thing that I can do at any point in the day. Like if at noon I have a task that I need to tackle, I can use this technique to deal with that task.
The Pomodoro technique, you mean?
Yeah. And it seems like it can be fairly fluid. But what Cheryl is saying, that her therapist wants like a more rigid schedule. I'm not sure if I'm
if I could share my screen again, I can show this idea here, because if you Google this, it will come up. Let me just pull this up here. So the Pomodoro technique, it's from those old tomato timers that used to be in like your grandma's kitchen, right? So plan your tasks. So what do you want to apply a Pomodoro to? You don't apply Pomodoro from wake to bed, right? But and you can split this up however you want. This is this is something that you should work with your therapist or your doctor on, like what makes sense. So I apply it to, because I was in school for 14 years, like I apply it to studying, right? So I need to do 4 hours of studying. So I'm going to do 30 minutes of concentrated work. I'm not going to let anything interrupt me. I'm not looking at emails. I'm not looking at social media. I'm not answering texts. 30 minutes of focused work. And then I'm going to take a break. And that break can be 5-10 minutes, and I can do what I want on that break. Whatever recharges my battery, I can go, take a lap around the library, get something to drink, go to the bathroom. I can, text people back, and then it's back to focus work. So whatever recharges my battery during my break. So for some people, it's a nap. For some people, it's laying down quietly with their eyes closed. But you kind of repeat that. So I need to do 4 hours of studying. I'm going to do 30 minutes, then 10 minutes, and 30 minutes and 10 minutes, and 30 minutes and 10 minutes. So I can get the task done a little bit more efficiently by adding the breaks. But there's no right or wrong way to do this. It has to be applied to something that makes sense for you. For some people, this makes sense for work. For some people, this doesn't make sense for work. I've had patients apply it to like running errands during the day or cleaning their house, things that they have a little bit more control over. But it's one technique. It's not set in stone. It shouldn't be that you Pomodoro your whole day. So yes, you're right. It is kind of shapeable and malleable, and you really just want to apply it to like one activity or 2 activities at a time and not the whole day.
If you have more time, like one thing to, I always encourage people to interview their physicians and their therapist too. Is there, outside of, do you see other people with sleep disorders, is there a question that you like to hear from your patients that come in, or do you think that might be helpful when you're talking with a potential practitioner?
For patients with hypersomnia?
Yes.
Asking them, what do you know about hypersomnia? Not like grilling them on their credentials, but what do you know about this condition? Have you seen patients like this before? Do you know anyone, if it's not their specialty area, do you know anyone who practices this in this community or in this hospital? But instead of grilling on like, what are your credentials, and but like, what do you know about this condition? I think that's helpful more in the setting of like primary care, or in a different specialty. If you're going to a cardiologist or someone who or urologist, or someone who doesn't know anything about sleep disorders, because they might have all the same stereotypes. Someone mentioned in the chat, like the biggest stigma is from medical providers. So if you want to kind of gauge where they're at in terms of understanding you and understanding your condition, that would be a good question. Tell me what you know.
Great question. Yeah, I think too, so much when it comes to therapists and the relationship that you have, there needs to be this trust that's there. There needs to be because I think you walk hand in hand with your therapist so much more than you do with a medical doctor who may see you
Absolutely
15 minutes every 6 weeks at closest, probably closer to 15 minutes every 6 months. So I think you're spending 30 minutes, an hour, depending on the length of the session with somebody. You do want to have a nice, comfortable relationship, a healthy relationship where there is some give and take. And I know that I've seen some great therapists who, I'm gonna be honest, I had to fire them after like 3 weeks because there just wasn't a comfort level that was there. And that's not an indictment on them. It was more.
Matt, you make a great point, because it's not necessarily, doesn't mean there's a problem with you, doesn't mean a problem with the therapist. It's just not a good match. And you might find a BSM specialist who has the credentials, but you don't click with them, right? You might come see me and you don't click with me, even though I am the BSM specialist. And you might feel more comfortable seeing a general therapist to talk about some of these issues because you click and you have a better relationship, and that's okay too. But Matt made a good point that the relationship you have with a therapist is going to be different than any other mental health provider.
Brian, I see you got your hand up.
Yes. Dr. Roth, thanks so much. That sounds like this acceptance and commitment therapy really has tons of promise. So I wish you very well. Several notes came up on the chat. with your research there. I saw one of the slides mention, I think, a Dr. Hayes. Is it Steve Hayes?
Yes.
Who, and would you recommend is he kind of the founder? Do you say ACT or ACT? But is he kind of the founder? And he's written some books. I had the chance to talk to a grad student of his who just thought his work was incredible.
Oh, yeah.
Would that be helpful to look into?
Yes, Steve Hayes is sort of the founder of ACT. There's several people who are, but he's probably one of the most prominent ones. He has a very important book that's actually a patient workbook called Get Out of Your Mind, Get Into Your Life. I can pull it up here, show you the cover. It's general, right? So it's sort of general towards a lot of different issues. It's not specifically made for any one particular issue. But Stephen Hayes, this would be kind of like the seminal book. And this is a workbook for people to work through. It's not a textbook. It's pretty inexpensive. You can find it pretty much anywhere.
Yes, thanks. I wanted to mention maybe just one other thing, which has helped me in the last couple months. It probably is behavioral in a certain sense, but I think Dr. Ong spoke at the Hypersomnia Foundation meeting. I can't remember if it was Charlotte or Indianapolis. And just one of his tips was trying to do, if a person is experiencing a lot of sleep inertia, trying to do things that maybe, or at least this is how I heard it, that maybe aren't as complex. Just trying to wake up. So I played piano as a kid, like maybe 8 or 9 years of piano, and then gave it up. But just recently I found this old music, very simple. I feel like I'm now an expert again in sort of one note here and one note there. But there's something about that where cognitively, I'm not trying to solve a complex thing. I think music in general is just so powerful, but we're all going to find our own ways. But something about, I can't remember some of his suggestions. Maybe you might have some. It's mindfulness in a way, but sometimes a focus on things that are just very, in that sense, maybe more right brain, just somehow not as, I'm going back to a procedural memory that isn't very technically challenging.
Yeah, I think when I encourage people for sleep inertia, and there's lots of different ways to try to overcome sleep inertia, don't stress out about picking something that's productive or meaningful. Just something, have something ready to go. Have some sort of plan of what you're going to do in the morning. It could be reading music and playing piano. It could be having a plan with a friend. We're going to meet up for coffee, or, I'm going to do an exercise class. Those are kind of big things to do. It can be as easy as, I'm going to make my coffee and sit on the couch and, look at the news. Just have a plan for what you're going to do. And if you really struggle with sleep inertia, it doesn't need to be something productive. It can be something nice and pleasant that you enjoy doing. And you say, oh, that's my enjoyable morning time. So you kind of are losing the association between how difficult waking up is. And you're replacing it, like you described, you're replacing it with something that's very meaningful to you. And so that makes you want to get out of bed. And from an ACT perspective, we talk about values. We talk about what's important in your life. So it might not be, oh, my goal is to get out of bed. Why do you want to get out of bed? Why is that important to you? Right. So talking about those sort of deeper influences. So Allison asked a question about working on disability. This is something that I will say is sort of my blind spot in, advocating for, because I don't really understand the process as well. It's something that I'm learning as well. It's a long process. I I don't know from a legal perspective exactly what to highlight or what to absolutely avoid. Because it's not about it's not always about what's true and what's accurate. It's about the legalese and how you word things and frame things. So most people have some sort of advocate or attorney that helps them through that to word that. I've definitely written letters for people who I have seen for a while. I don't think it'd be helpful for someone who sees you once to write a letter for you. But I just had a patient who has been going through this process for a long time, and I wrote a letter talking about our treatment, that we've been seeing each other for a year, and all of a sudden it just went through. And I don't know if it was my letter, but I like to think that that was helpful for me to discuss and talk about what this condition has done to her. So, you know, your physicians, your psychologists, that's the way they can be helpful, is to describe um um to describe in a letter, or, and I always am very open with patients about, what do you need in this letter? What do you want me to say? What do you not want me to say? And it's not that I'm gonna lie, but do you want me to exclude certain information? Do you need me to include very specific dates, things like that?
We had a piece, I don't know if it's up on YouTube currently, that we did a UNIGHT on. It goes in depth into that. I think the other question there too, you know, Allison, is it does vary state to state too. Some states are more rigid with their enforcement of disability. It's a very nuanced question. And even though they don't acknowledge this publicly, age does play a factor. They're more likely to approve disability for someone who's a little bit older versus a younger employee, a younger person. I've got a lot of very strong thoughts and strong language about that, but I'm not going to share that publicly. But you know, the reality is it's a tough process. It's also multiple stages. Denial in certain states is almost guaranteed, and then you have to go through an appeals process. So I think my personal recommendation is to be patient and just follow the steps and make sure you don't miss deadlines. And then again, I think working with both a medical doctor and a behavioral specialist would increase the likelihood of getting that across the finish line. It's a good question, though.
Yeah.
And Alicia, I'll just say it's one that I don't think a lot of people are prepared for. I've heard so many people, physicians or therapists. It's just a tricky thing. It's a complex process that typically having a lawyer walk you through it is probably a best step for a lot of people. But it can be done without one.
From my perspective as a psychologist, I can't write a letter like that after just meeting you once or twice. We have to, you know, develop a relationship, go through some things together, have some time together before I really understand what your life is like and what you're going through. And it seemed to make all the difference for this one patient, for me to really, really know her very well, for that to work out.
All the more reason to establish that relationship yesterday, and tomorrow, you know, if not yesterday, or today, you know, then you can do that the better. And as someone who has seen the value of talking to a therapist, I cannot express enough the importance of having a safe place to go and talk and share about the struggles of living with this condition, whether or not they're specifically trained in a certain approach or not.
There was one question similar to this, like,
Yeah.
you know, what should you treat first? You know, the hypersomnia or the mental health issue. I think it's hard to say that they're different things, right? And I don't think it's, you don't have to have someone who specializes in sleep medicine or hypersomnia to be a good, helpful therapist that is helping you take care of your mental health. a therapist worth their salt is going to be really interested in just learning more about what that is and putting that in their toolbox. But a really good therapist is going to be able to work with you on, you know, different mental health issues like depression or anxiety. It doesn't have to be someone with a board certification in sleep medicine. And like Matt said, that if you might need someone that really connects with you, you feel really understands you, you feel that safety, you feel that trust, they are really genuinely helping you, and they don't have any experience in sleep medicine.
Yeah. I noticed on a couple of the slides that you were sharing just the crossover with the depression and anxiety, and you know, and talks with one of my friends who's a sleep researcher, Jesse. You know, he talks about how depression is a symptom of hypersomnolence, and hypersomnolence is a symptom of depression. And so, you know, yeah, it's this circle. You don't know where, you know, it doesn't really, also, it doesn't matter necessarily where one end and one begins, because I don't know if you can even define that, but it's so important to find somebody to at least address that with you.
And if it doesn't matter where it ends and begins, it also means that you can approach it from lots of different angles. You know, you can approach it from the depression side, you can approach it from the hypersomnia side. I think where you might find the barrier is someone who's not familiar with a hypersomnia condition may encourage you to do things that they encourage for people who are depressed that maybe you're not capable of doing. So things like what we call behavioral activation. So, you know, even if you don't feel great, even if you don't feel your best, get out there, go do something, make a plan, see a friend, do a hobby, do an activity. That might not always be possible for a person with hypersomnia symptoms. But that's where it's your responsibility to be assertive and say, this isn't going to work for me because of this, this, and this. What are some other ideas?
All right. Any other questions? If not, I did have one question. Just in relationship, you know, working with Dr. Munt on the familial aspect of this condition, I was going to ask if you have any recommendations for maybe perhaps working with, you know, almost a couples therapy like approach in terms of learning to live with this condition, because I know it can be challenging. It also can be helpful, I think, to have a parent and child, you know, possibly work through some of these things together. But it's just such a condition that impacts all aspects of life. So just want to hear your thoughts perhaps on, you know, working through it together.
I love the work that Dr. Munt's doing to look at, you know, the broader impacts, you know, with spouses and different relationships, and trying to understand that, because we're connected. This is not all happening, you know, just within ourselves. It's happening to all of our connections in life. Again, you could find a really great marriage therapist who doesn't know anything about narcolepsy or IH, who is just a really good marriage therapist who can facilitate communication very well and teach you how to advocate for yourself, advocate for your needs, talk about your future. And they may not know anything about hypersomnia. And you might have to provide them some education, but you know, it's still sort of the basis of someone who's like just a really good couples counselor, or like a family counselor, or who deals, you know, with who works with children and their parents. I'm sure, you know, most of you are tired of this, but you are the one who has to provide the education for it. But a good counselor in that area, parent and child therapy or couples therapy, you know, is going to know the basic skill set that you need. You still need those basic skills of communication and of assertiveness, and in order to, you know, make that work, with or without hypersomnia knowledge. But you know, you're really highlighting the need for our sleep army to grow, our sleep therapist army to grow. So because it would be great if we could do both. if
Yeah.
everyone could know both.
You mentioned how important it was in your sessions that that the participants really wanted to talk about their pain and loss first.
Mhm.
And I'm wondering, as a caregiver to someone who has this condition, like, how can I lean into that a bit? And will that help get to the other stuff?
It's a really good question. What questions have you asked in the past? I'm a therapist. I'm going to throw it right
It
back
is
at you.
difficult to get time together to ask questions.
Yeah.
There's very little time when
Mhm.
he is awake and alert and feeling so. Yeah.
Mhm.
Usually not when I'm available and not working.
Sure. For my experience a lot with patients who come in with these disorders is they're used to coming in and giving a list of their medications, a list of their symptoms, a chronology of what happened. All of those things are very important. And then I sometimes come out of left field and say, tell me about your life. Tell me about your life. And it's very telling because most people's life revolves around these conditions, like you're saying. So that's very telling sometimes. But tell me about what interests you. What are you excited for in the future? What are you looking forward to? What do you want to accomplish? Or sometimes accomplish kind of puts a little too much weight on it. But what are you interested in, and how do you want to live your life? What do you want your life to look like? And I think that opens up that conversation for talking about, well, these are the things I've lost and I want those things back, or these are the things I've never had and I want, you can still feel lost for things that you've never had. So instead of focusing on what are your symptoms, how do you manage it, I try to go in the direction of what does your life look like? Are you satisfied with that? What would you want differently? And how do I help you get to that point? And it probably has to do with managing hypersomnia along the way. But that seems to be a good opening for having more talk about those things as they relate to hypersomnia, but they're different.
Yeah, to answer that question too, just from my perspective, one of the things when you and I first talked about acceptance and commitment therapy that really resonated was the grief piece, and having to grieve the loss of the dreams that I had, this normalcy, this idea of this is what I would accomplish. And I sat in anger for a long time, and that I know that's a part of that grief process, but it really is a constant effort to get to acceptance, and then I can start learning to identify how do I make the most out of the hand that's been dealt to me. I can be mad that I have this neurological disorder that is keeping me from accomplishing X, but what can I accomplish? I redefine success, double down on, if I have a really bad day, my main goal is to get out of bed and just be a good dad and a good partner. If I don't get those emails out, if I don't do the extra chores, it's okay if I meet that one, that one goal that's tangible, that's real, that I can at least I can go back to sleep, middle of the day, end of the day, whatever that looks like on that particular day. But knowing that, hey, I took a step forward, I may not have knocked it out of the park, but I at least kept my value in place of being a good dad, being a good partner. So I don't know if that helps. It's not that took years to get to that place, because there was just a whole lot of anger blowing around. And I know that ended up being a big part of a failed relationship early on. But I think, again, figuring out how to get to that point and give love and grace, extend grace too. That's something that I have to remind myself. I have to extend grace to myself as much as I want to extend it to a peer that reaches out. And again, easier said than done.
Sure. And acceptance, to be clear, in the concept of acceptance and commitment, it's not like, oh, there's nothing I can do about it. Right? Because a lot of people think that that's what we mean by acceptance, is I just have to give up. And it is sort of giving up, but in a different way. It's sort of like Matt said, I acknowledge that this is part of my life, but it's not acceptance of my life is bound to be terrible. It's acceptance that this is part of my experience. But moving forward towards things that I actually want my life to be like.
Bingo.
Well, thanks so much for having me. I'm so happy to be here and meet all of you, and hope to see you at the Beyond Sleepy conference. I will be there. I'm really excited to attend. So if you see me and you want to talk, please come up. We're going to be in Houston, and I can be bought for a sweet tea. I can be bought for a sweet tea. So I don't get sweet teas up here in Cleveland. So if anyone wants to offer me that, I'll be bought for that.
Well, I just want to thank you just from the bottom of our heart. You've given a lot of your evening to us and a lot of wisdom here. And I know that this is also your job, but to donate this wisdom here, I think is just so important. And I think it's going to help drive the community forward. And so thank you for being so gracious of your time. And I will buy you a gallon of sweet tea. But I mean, it's no worries. I can even start smuggling some of that up to Ohio if need be, because it comes out of the tap down here in Nashville.
It does, right?
So it's maybe that's brown water. I don't know, but we add sugar to it.
It might just be brown water. I don't know.
Yeah. So
all right.
Claire, bye, Dr. Roth. Claire,
Thank
did
you.
you want to take it home for us?
Yeah, thank you. That's such a warm invitation that she's given all of us, I think, to meet Dr. Roth in person. So as I said at the beginning, do check out our website and social media for registration, because it's still open for Beyond Sleepy. That was an incredibly sobering and helpful meeting. So thank you all for coming.